Welcome to the Dr. Franken Steve Podcast with your hosts, Dr. Frank Williams and Dr. Steve Snodgrass, MD, FACS, where we discuss a broad range of topics without limitations. Let's get to it. Here's Dr. Frank and Dr. Steve.
Hi, welcome. This is the Dr. Franken Steve Podcast. We're going to be covering a lot of different topics off of many different subjects, but an awful lot on health and healing, as well as health and healing in the arts, and many other topics that affect your everyday lives. So I'm Frank. This is Dr. Steven Snodgrass, MD, former chief surgeon. I'll let him go over his background, and I want to welcome all of you here, and we're going to go ahead and get started. And the first thing I want to do is ask Steve a little bit about his background and have him explain that to you. Then we're going to go right into what the subject matter is today, which is concerning healing healthcare and you being a patient advocate for yourself and your loved ones. Steve, would you like to go ahead and tell us a little about yourself?
First, welcome everybody. My name is Dr. Steve Snodgrass. I'm a former chief of surgery at HCA Greenview Hospital. I'm also a member of the American Medical Association and a fellow of the American College of Surgeons. I've authored several scientific papers, books, both fiction and nonfiction, that have been published, and an entrepreneur. And Frank and I got together because of our similar backgrounds, and we wanted to start this podcast to begin with healing, because right now, for you as a person and your family, we're at one of the most important times in history concerning healthcare. And so we wanted to make sure that you understand who is taking care of you and how you can be your own advocate.
Yeah, so what we're going to be talking about today is basically physicians versus non-physician, and the scope of that work, the scope of as far as who's actually taking care of you, as Dr. Snodgrass said, and then I will let him explain what he's actually talking about, where his reference material comes from, and then we will just kind of do a chat back and forth as I ask him some questions so that he can explain and maybe answer questions that you have, or questions that you don't really realize that you have at this point, but may lead into a better healthcare experience for you and your family, and for you to be a better advocate for yourself or loved ones within your family and friends. So, Steve, you'd like to tell us what you want to cover?
Yeah. First of all, I am in no way representing the American Medical Association during this podcast. My thoughts or my interpretations are my own, and they're based on my experience as a physician surgeon, as well as combing through and reading extensively credible medical surgical literature and my interpretation of that. So I want to make sure that that's clear. But we as physicians, we understand that healthcare teams are composed of multiple professionals. This can include nurse practitioners, physician's assistants, pharmacists, and physical therapists as examples. We understand we can't do it by ourselves, but everybody has a defined role, and that's based on their own level of expertise and training. And what we want to do is we want to combine all of those and make your experience as a patient the very best that it can be. And that being said, there's a push to expand the scope of practice for non-physicians to work without physician supervision. And this could include writing prescriptions and even surgical intervention. And so this is being referred to as scope creep by the American Medical Association. And it's been my understanding from talking to a lot of my colleagues, as well as people in the general population, they really have not paid much attention to this, but I feel it's extremely important we understand the dynamics of what's going on in today's healthcare.
Right, so looking at that, let's take this and break this down even further for everybody. So let's take a look at each individual particular area and their expertise versus, or rather a non-physician versus a physician. So if you would, I'd like you to start with maybe like nurse practitioners. Tell us the training, the background, the differences, and where those can come into play as far as taking care of someone healthcare-wise.
Well, first, let's define the word physician. We're going to say a physician is a medical doctor or a doctor of osteopathic medicine. So when we say physician during this podcast, that's who we're referring to.
Like an MD or a DO.
That's correct. That's correct. And we've broken this down into different areas and different personnel within the healthcare team, and we want to compare that level of training to that of a physician. And so we'll start with nurse practitioner. And if you look at the length of graduate education, it's 2 to 4 years, and there are online-only programs allowed for nurse practitioners. For physicians, it's 4 years of medical school, and obviously there's no online medical school. And if you look at the years of residency or fellowship training, the nurse practitioners, there's no requirement there. For a physician, it's anywhere from 3 to 7 years, depending on what your specialty or even subspecialty may be. And if you look at total patient care hours, on average, the nurse practitioner will average 500 to 750 hours of training, while a physician will undergo anywhere from 12,000 to 20,000 hours of training.
It's a big difference. It's a lot of training.
It is. It's a big difference. And when we were residents in surgery, I was on call every other night, every third night. And so we really did not miss much of the action. Our exposure to anything and everything was pretty incredible and very intense. I will say that.
So looking at that from just a personal standpoint, and doing some of my own research, as you had sent to me, and plus I did some research in the medical field also as far as backgrounds, it seems to me that there's an awful large push, an awful amount of agencies, because of cost cutting and because of lack of, residents and lack of MDs or DOs, they're really starting to push nurse practitioners as basically primary care providers. And so my concern is that we don't turn into like a socialized medicine state.
Well, I think that there is definitely a shift that is trying to occur. And obviously, physicians, we have always seen ourselves as leaders and taking the most responsibility for everything that goes on. For example, when I was in my case during surgery, that anything and everything that went on in that room was my responsibility. And no matter who else was in there, nurse, anesthesiologist, nurse anesthetist, no matter what, I was responsible. And so physicians are taught that, and we're exposed to patient care in a way that no one else is. The bond between physician and patient is one of the strongest bonds there is. And I can tell you from my standpoint, the fact that you would have somebody put to sleep on your operating table, really a controlled death, and they would allow me to cut them open, fix what's broken, or take out whatever needs to be taken out, sew them back up, and then take care of them for months until they were back literally on their feet again. That is quite a bond that does not exist anywhere else.
Understandable. Absolutely. And like I said, my only concern, and again, it's nothing against nurses, not anything really against nurse practitioners, but, as my young daughters always said, know your role. So when places or organizations or companies start pushing nurse practitioners, which to my understanding, and I may be wrong on this, you may be able to speak on this, Steve, a little better, have to be overseen by an actual MD or DO. And that just is not the case more and more, because while they may see a certain amount of patients, I would challenge any organization, and that's just me personally, not speaking on Steve, they may anybody else, so that we can see how many actual doctors are reviewing every single case that the nurse practitioner is actually seeing that day. Because in some urgent care facilities, some medical practices and clinics, they have to be seeing, anywhere up to maybe 20 plus patients a day. And I would doubt, and I may be wrong on this, that if you've got X amount of nurse practitioners handling that, there should be an MD who goes over every one of those. Now, if it's something like, hey, I got a staple in my hand, I need it taken out, I understand that. But when it comes to something that could be on a more serious note, if something's missed, then who is liable for that at that point?
Well, the thing about it is, people think that, I'm going to put it this way. There was an old story that was taught to us in medical school, is that's when you hear hoof beats, think horses, not zebras. And that just means that, yeah, there's a lot of common things out there, but zebras do exist. And part of the expertise of a physician is we take all of our knowledge base, all of our experience, we do the history and physical examination thoroughly, and we know what to look for as far as the differential diagnosis goes and what tests need to be ordered. And what we're seeing is that when some of this non-physician care is taking place, it's actually increasing the cost of health care. There's more referrals to other doctors. There's more referrals to the emergency room. And I believe that there's more medical errors that are taking place as well. And this is especially true like in dermatology. There's a study out in dermatology about missed melanoma in situ on non-physician diagnosis versus physicians.
Melanoma meaning cancers?
Yes, and melanoma in situ means that at the very beginning stages of a melanoma, and it's been shown that physicians will pick that up, and non-physicians have missed that more. And where that comes into play is a melanoma is a deadly cancer, and the earlier you get it, the better chance you have of curing it. And so you want to get that as early as possible. So there are several marked differences between physician care and non-physician care. And again, we are not trying to pick a fight here. What we're trying to do is show that there's a collaboration and cooperation that we want to exist, but there's a push to push physicians out of care. And that's very, very dangerous.
Yeah, and as I brought to your attention, because I seen the commercial here locally in Kentucky, because I'm the caregiver for my 95-and-a-half-year-old father-in-law, since I'm retired, and I love doing it, but I take him to doctor visits, I take him to anything he needs, and administer, give him his meds and stuff during the day, and evenings if there's something needed. And we have sat there, and even he noticed it and mentioned it to me. He said, I didn't know that they're doctors now, because there's a commercial, and I realized that the Nurse Practitioners Association, whatever that might be, these were just probably different organizations running that. But the commercial was showing different patients who had gotten their life saved. But then the statement of, the heart of a nurse, but the brains of a doctor. And to me, that's not true, because I've had my own personal experiences. And there are some excellent nurse practitioners. My wife is a breast cancer survivor. She goes to, a major breast cancer center here in Tennessee. Excellent care, nurse practitioners down there, and their specialty do an excellent job because they're directly under the oncologist and under the surgeon who oversee everything. However, we have had incidents before where a nurse practitioner oversteps their bounds and then tells me basically they want to be called doctor because they got a PhD or something else. And I said, you're not in this facility in a hospital be called doctor. You are, and I'm not knocking them. Like I said, as a nurse practitioner, if I want to talk to a doctor, I need to talk to somebody with an MD or a DO behind their credentials, because I want the most care, and I want to make sure that if my wife's going through it, we have 3 daughters, and I don't want to see anything happen to her, so I want to make sure everything is picked up on and everything is followed through, especially after her surgery, and thank the Almighty God that she's doing well. But that's something I don't want to have to go through, because I've had this before, a couple incidents with nurse practitioners, and asked them to have the doctor come in and oversee their diagnosis when I went to see him, when I was supposed to see an MD, and then actually get a little testy with me. And I didn't get testy. I just explained, my insurance is paying for an MD. I'm sure that's what's being charged for. That's who I schedule my appointment with. That's who I want to see what is going on. I don't, not knocking, like I said, their profession, but if it's something that may be serious or something that there may be an area that I don't want overlooked, I am definitely using an MD or a DO for that.
And I think that there's a lot of confusion, because understandably, in each of these different professions, they're starting to offer degrees, doctorate degrees, if you will, and it's confusing to patients and their families when somebody's introduced in a healthcare setting as doctor, because doctor is meant to be
Medical
MD
doctor, yes.
or DO, and so it's a bit confusing. And I think there's several bills out there in regards to all of this. So I feel like that for me, when I talk to my physician colleagues and other friends, patients, that sort of thing, there is a large degree of confusion. And I think this leads to a lot of potential problems. Everybody needs to know who's taking care of them. And, I wanted just to also, we wanted to discuss several different professions involved in all of this and compare them to a physician's education, and then let people decide for themselves about how they want to get treated. But I would like to say to every person, you must know who is treating you and what their background is and what their level of expertise is. And you only have one body, and so you need to take the best care of it that you can. And knowledge and education are very powerful.
Yeah, along with experiential training.
Yes.
Which is the residency and everything that they spend, or even in doing fellowships and stuff, depending on their specialty as a doctor. But is there anything else you'd like to add about nurse practitioners, or would you like to move on possibly like physician's assistants, or?
Now let's go on to physician's assistants or PA. Well, their length of graduate education is anywhere from 2 to 3 years. Again, a physician is 4 years of medical school. And I would like to add that when you say 4 years of medical school, and we say it nonchalantly, it is extremely intense, because the pre-med undergrad is difficult enough. And then when you get into medical school, it's not like you start over in pre-med. They just assume that you remembered everything that you were taught in pre-med. And they load you with so much material that when you first get there, you think like, how could anybody ever do this? Because it is so overwhelming. And some of the smartest people that I've ever met in my life who were in med school, and they just said, well, for the first time, undergrad really didn't challenge me all that much, but med school, essentially, it really took everything out of me. So it's quite an experience to go through that. And so let's not talk about it nonchalantly. And the years of residency back for a physician's assistant, they're not required to have a residency program. Again, a physician is anywhere from 3 to 7 years. And the total patient care hours for a physician assistant are 2,000 hours on average, and a physician, again, 12 to 20,000 hours. So there's a marked difference.
That's a lot of difference, yes.
Yes.
And as we said, we're not knocking, we're just trying to educate the general public. There's a movement within healthcare to try and do this, but there's not a lot of movement and a lot of campaigning going on for the general public, because no matter what side of the political spectrum you fall on, as Steve and I talk about sometimes, it's all about that mighty dollar. How can we conserve cost, still provide some type of care, and charge for it to the insurance companies. Healthcare is literally globally a $12 trillion annual business. That's right, $12 trillion. You can look it up, research it, you'll find. The American healthcare system alone is what? It's
probably right at anywhere from 3.5 to 4.5 trillion a year.
Trillion a year.
Yeah.
So everybody's trying to get their share of that, and everybody's trying to cut costs, and that's understandable. But when it comes to people's health, you want to have the healthiest nation in the world, not just. I lived under socialized medicine when I was in the military. As Steve knows, I'm a retired law enforcement officer, also a U.S. Army veteran. And when I lived overseas in Great Britain, nicest people in the world, our staunchest allies. However, I had a couple experiences under the socialized medicine system, and I got to tell you, there is nothing like the U.S. healthcare system. The socialized medicine system, while it's fine, and they will actually make house calls. I'm not sure if they do it today because that's been a couple decades ago, but I will tell you that when they show up, it is not the most sanitary to do things or sew you up in places if you're in a barracks or an apartment, or you're at a place of business, and that's where they come to. Now, granted, we have emergency situations here in the U.S., but this is an everyday thing for them. They can come and temporarily fill a tooth, do whatever they need to do there, until they can see you the next day just to get you by. And the quality of care, while it is okay, it is nothing like the standard in the U.S. holds. And we're just trying to make sure that as a healthcare advocate, which I am, and Steve is a healthcare provider, a retired surgeon and an MD, that we get this out so that the U.S. does not start heading that way. This is not a hate podcast, because we're going to be covering a lot of subjects, but as Steve said, this scope creep is becoming increasingly more and more problematic here in the U.S.
Yeah, I think that we look at it from the standpoint of being the leader of a team, and we feel like as physicians that we're being more in question as far as our leadership role, and we do feel like that there are some adversarial relationships that are pushing against us. And so we're basically going to push back. And I think one of the reasons that I feel people that are physicians, I think they should join the American Medical Association. I know that a lot of people will say, what does the American Medical Association do for me? It doesn't do anything. I'm going to beg to differ, because sure, there's some policies and there's some things that I've been a member for decades, and I haven't agreed with every single thing that the AMA has come out with. Mm-hmm. But on the other hand, they're a strong advocate for patient care. And that's what it's all about. We're all patient-centric, or we wouldn't be having this discussion anyway. But I feel like that we're getting away from some of the things that are absolutely basic. And it can be to the point of being dangerous, because I can tell you, there's been many times in the operating room, I have faced things that you didn't see coming, but I knew what to do, because I'd had those kinds of experiences before during my training. And so basically, I was 911. I didn't have to call it, I was 911. And that's who you want taking care of.
Absolutely. Yeah. So getting back to physician's assistants, they're a step up, obviously, from a nurse practitioner, I take it. But do they still have to be overseen by an MD or a DO?
I don't know if I could call it a step up, but I'll just basically break everything down into physician, non-physician, and but they do have a level of responsibility. But I feel that every non-physician should be overseen by a physician, without question. And the next topic, or the next specialty, is one that's near and dear to my heart.
The optometrist and ophthalmologist?
Yes.
Okay.
That is correct. And I'm a glaucoma patient, And I'm very fortunate to have my eyesight, but I want to go over optometrist versus an ophthalmologist, because it's a big difference, and a lot of people don't think there is a difference there. They think they're interchangeable, but they're not. For example, the length of a graduate education for an OD degree or for an optometrist is 4 years of a college of optometry. Again, a physician, 4 years of medical school plus a year of internship. Regarding years of residency and fellowship, an OD, that's not required. But for physicians, it's 3 to 5 years. And the total patient care hours for an OD would be a 1-year clinical rotation. And again, for physicians, you're looking at anywhere from 12 to 20,000 hours.
Okay, so not to interrupt you, Steve, but I have a question. When you say, optometrist versus physician, in this instant, you're talking about optometrist versus an ophthalmologist, which is a doctor.
Yes.
I mean, which is an MD, basically.
Right. Ophthalmologist would be an MD or DO.
Okay.
Versus an optometrist.
I just wanted to make sure, because some of the numbers are a little different than some of the others when you mentioned physician. So that's the reason why, is because that's a different specialty.
Yeah. And it should be known that in their years of formal training, that optometry students are never trained to perform surgery, either with a laser or a scalpel. And obviously ophthalmologists are. And 40% of ophthalmologists will go on and do additional training. For example, like a 1 or 2 year fellowship. For example, I see physicians at a large, major institution at an eye center. And these ophthalmologists they took specialized training not only for their ophthalmology part of their training, they went an extra year for glaucoma. And I want to go back to this thing about being your own advocate, because everybody says physicians are the worst patients, and that's really pretty true. Whether we like it or whether we don't, everybody that is a human being will eventually become a patient. You don't think you will, because you go through those years of your life where you think you're invincible, and then something happens to you, be it an accident or you get sick, and all of a sudden you're shocked. You're hit with this shell shock of just like, oh, this really can't happen to me. And I felt like that was the case with me, because I just thought I was having some problems with my eyesight. I just needed a prescription change. And then once I got into that system and found out that I had glaucoma, I had to have 2 surgeries on each eye very quickly to save my eyesight. And the doctor that did my surgery, well, it was an interesting experience, to say the least, because I started asking him questions about where did you train? Where did you go to medical school? Where did you train in ophthalmology? How many of these surgeries have you done? What's your complication rate? What's the worst thing that ever happened to you during this kind of surgery, as far as one of your patients, what was the worst case scenario, and how did you take care of that? And he looked at me just like, are you crazy asking me these questions? Because, you're not supposed to be asking me this sort of thing. And that was a physician. That's one physician talking to another physician. And so, I grilled him on it. And because my eyesight was at stake. And I wanted to make very sure of the person that I had confidence in that person who was taking care of me. And you should be no different. You should be no different. I don't care whether it's a surgery that you're facing or any kind of medical illness that you're facing or your family. You must ask these questions. And if you feel like that you're going to be nervous before you go to an appointment, that sort of thing, write your questions down and then just put them on a piece of paper and just go through them one by one on a checklist, because this is your health. What we're trying to do during this podcast is we are trying to make things as good as possible because we understand you're compromised, you're afraid, you're nervous, you're put in a situation where you're normally not thrust. All of a sudden, you're not in charge of your life anymore, someone else is. And that's very difficult to accept, especially for somebody like you and somebody like me, who is used to being in charge of their own life, and all of a sudden, you have to give up that control. And that's a very difficult thing to do. And so you need to know who's taking care of you and what kind of experiences they've had.
Absolutely. And going back to, and I love my family's optometrist office. They've always taken care of me and my family applied. So my own personal experience from that is, and you know this because I had called you and asked you about this back when, and this has been, probably close to 10 years ago. I had like a mole on my face that I wanted taken off. Wasn't very big, but I was talking to the optometrist because we were just, talking about surgery he had or something was going along. And I said, yeah, and I'm looking at, going to a plastic surgeon here, just like them, because that seems to be the best, and they seem to be the best by reputation since they're an actual surgeon. And the optometrist said, well, I just got back over the holidays from a 40-hour certification course on doing laser surgeries for patients for them. And this was up under my eye, and I said, well, don't take this wrong, and I understand you're an optometrist, you're my eye doctor, but I'm not sure that I feel comfortable with me being one of your first patients and you doing a laser treatment or a laser surgery or even a scalpel, whatever you need to do, to me, if that's not your area of expertise. And we went back and forth, and he understood, and then about 3 weeks later, they had a big push for the program within the optometry office, then they dropped it. And I don't know why they dropped it, they just dropped it and never mentioned it again and took all the stuff down and all the information about it and stopped doing it. So, but I don't think I'd want my eye doctor operating on and cutting me open or doing anything like that. But, like I said, it didn't end up bad because I had Steve here, Dr. Snodgrass, to fall back on, and he said I would go somewhere where that's their specialty, because you're talking about something that's close to your eye because of his issue. He said, you don't need something that could mess up, and they're not a surgeon, they're not surgically trained, even though they've been doing a 40-hour course. And that's usually in the cosmetic surgeon's area or somebody who's used to doing like dermatologist surgery. So, and I appreciate that, but that's just work, and I understand people get that because they can add different pieces to their practice to try and bring in extra revenue. But when it comes to health or your health care, people just need to, as I'll say this again, they need to stay in their lane for what they do. Because everybody's needed, but you need to stay in your lane for what you do.
Well, it's basically, realistically, if you look at a couple of different instances I've had, one, I had a lesion by my eye, and, it started bleeding, and so I knew this was a skin cancer. And I talked to my ophthalmologist about it, and I said, will you take a biopsy of this, or how would you handle this? And they said, are you crazy? They said, we wouldn't touch that with a 10-foot pole. We're going to send you to an oculoplastic surgeon because your eyes have had so many different problems. This is not another one we need. And so they sent me to an oculoplastic surgeon. And that's about as specialized as it gets. And of course, this guy had operated on just thousands of patients. He's a world-renowned oculoplastic surgeon, and that's why I went to him, is because it was a squamous cell carcinoma right by my eye. They did what's called a Mohs procedure, where they tried to take as minimal tissue as possible because they wanted to leave it with a good cosmetic result, which they did, and the surgery was very successful. And there's another area where I had a right angle hernia, and my options were for an open herniorrhaphy or one done with minimally invasive laparoscopic technique. And I talked to the surgeon about it, and I said, how many of these have you done? What's the learning curve here? And he said, he goes, since you are who you are, he just goes, I can tell you that I'm going to say after your first 50, you start feeling pretty comfortable. with yourself. I said, well, where am I on that list?
45.
And he said, like, well, you're like number 355, something like that. And I said, that's good enough. I said, the guy at the time, the leading surgeon in the world, had done 800, and he was in Connecticut. I'm not. And so I decided to go with this surgeon that was 55 miles away, and the surgery went well. But the whole point was, here's a guy that had been a general surgeon for decades. He had just started using the laparoscope to do hernia repairs, and he was honest with him. He said, for the first 50, there's a lot of things to consider, and it is a learning process. But after that, he said, like, I just breezed right through it. But the whole point is, the more you do, the more you see, the more you train, the better you are and the better you get.
Absolutely. And, we're going to be covering several more non-physicians versus physicians in our next couple of podcasts. This is just our first inauguratory podcast, so we want to make sure we covered everything. And I think as far as information and as far as what we're looking to do, I think we pretty much covered those areas, and we'll be covering pharmacists versus physicians, a naturopath versus a physician, psychologist versus psychiatrist, all these things are going to be covered, and we'll be doing those as we go on. So, in closing, is there anything you'd like to add, Steve, before we let these people go?
Well, one of the things I feel like that people need to understand, again, I don't want to beat this to death, but then again, I do, because I think it's so important. I think it's one of the most important areas or topics to discuss is your own personal health and the health of your family. And so you need to understand that you're going to have to give up control of your body to another person, and you need to know the qualifications of that person. You need to know where they trained, what degree they had. If you're facing a surgery, how many times have they done that operation? Do they feel comfortable with that operation? And I think that this whole thing of scope creep, they need to understand it increases the cost of health care. It does not decrease the cost of health care. And also, you just have to look at the level of experience that you're comparing to physician versus non-physician.
Thanks for listening to the Dr. Franken Steve Podcast. If you enjoyed this podcast, please hit follow or subscribe on the link provided so you can stay up to date on new episodes. Until next time, stay healthy and stay safe.